Good morning. Today I'm going to discuss with you one of the important topics in the field of nephrology because it needs a special assessment, special management for a very vulnerable sector of population, the geriatric age group patients. So today I'm going to discuss with you the geriatric nephropathy under the following sectors. I'll start with brief introduction, then what's meant by renal aging, and then chronic kidney disease in elderly, definitions and guidelines. What about blood pressure, hypertension, and its proper management in elderly? How to use drugs proper in this age? What are the indications of renal biopsy? And what are the different expectations from the young patients to the different sectors of kidney disease, acute kidney injury in elderly, frailty, and renal replacement therapies, and then I'll end with conclusion. I like to start with this slide from the bulletin, reflecting that aging is increasing all over the world. If I start with United States, this is the United States population aged 65 or older. If we are here today, this is 46 million, and by the year of 2060, this is the expectation that the number of this population, 65 or older, will exceed 90 millions in the United States alone. Moreover, the sector of persons ages 85 and more will be increasing too. The aging world is not restricted to the United States of America, but all over the world. Here, this is the different regions in the world. You can find here the distribution and the percentage distribution of population aged 65 and over by region 2015 and 2050. So 2015 can look at here, for example, Asia includes large proportion of these elderly persons. And this is the expectation by 2050. Here I want to fix to the definition of old, because old age is different from country to country. But I think the most interesting and accepted definition for me is to stratify all the persons into old, and oldest old. Old from 65 to 74, old between 75 and 84, and oldest old 85 or above. This is a classification. Another classification is to consider 65 to 74 as young old, 75 to 84 middle old, and 85 or more as old. Whatever the certification, this is just to give you idea about the age of these persons. When we speak about old age, we speak about vulnerable group. We speak at decline of all body system reserve. Let us to concentrate on our topic, on the kidney, renal aging, and what's meant by renal aging. If I start with this nice article that discusses the substantial loss of nephrons in healthy human kidneys with aging. This is the data from 1,638 living kidney donors at Mayo Clinic and Cleveland Clinic. If we look at this figure, the figure shows that with increasing the age, what do you see? The number of non-sclerosed glomeruli, this means healthy glomeruli, decreases, and the number of global sclerosed glomeruli increases. This means that by age, there is decline of healthy glomeruli and increasing the percentage of globally sclerosed glomeruli with subsequent reduction of GFR. So we should deal with aged persons as special group of persons. This is the first point, nephron loss by aging. What about kidney volume and how to assess kidney volume? We can assess kidney volume by CT scan. We have the kidney cortical volume as reflected by this white bar. Gray one reflects medullary volume, and the black one total kidney volume. So within these ages, can find stable volume, but with aging there is a change. This among 1,281 living kidney donor, cortical volume declines, whereas medullary volume increases, making total kidney volume relatively stable until about 50 years of age. However, after which medullary volume doesn't increase anymore, and the total kidney volume begins to decline, as you find here in these sectors of ages. So this is an important point. So the first point is the number of healthy and sclerosed glomeruli I mentioned in the previous slide, and here I stressed upon kidney volume. So there is the diminution of the kidney volume by age. Another interesting point is the sclerosis score by age. The sclerosis here, they looked at 1,200 living kidney donors. Sclerosis score is defined as total number of chronic histological abnormalities between any global glomerulosclerosis, any tubular atrophy, interstitial fibrosis, and arteriosclerosis. We can say score is 0, 1, 2, 3, 4. As you see here, 0, 1, 2, 3, and 4. What do you see? By increasing the age, there is tendency toward increasing the score of sclerosis. Another interesting point, the number of cysts. Number of cortical and medullary simple cysts increases by age. Among 1,948 living kidney donors. So this is just, so again, by aging, there is increasing global sclerosis of sclerosed glomeruli. There is decreasing of kidney volume and increasing sclerosis index and increasing number of cysts. What about GFR? Senescence or aging of the kidney is reflected by progressive increasing nephrosclerosis with loss of functional glomeruli and decreased overall kidney function as determined by GFR. Here, this is measured, and this is estimated GFR, measured by clearance and estimated from formulas. So the decline in kidney cortical volume from nephrosclerosis is compensated by nephron hypertrophy of the remaining nephrons, most notable in the medulla. As the patient's ages go beyond 50, this compensation is less adequate, and total kidney volume begins to decline with declining of kidney function. So you can see here, with increasing the age, both measured and estimated GFR, as you find, is declining significantly in women and in men. A very important point is the functional reserve. Here we can say that the minimum required function of the kidney is preserved most of the time, whereas the functional reserve decreases with age. The kidney undergoes age-related changes, reaching full functionality after the age of 5 years, and suffering a slow but progressive decline in its regulatory range of function, starting at the age of 20 years, as well as in function in GFR at higher age. Just to understand, if you look here, the functional reserve is declining by age. The question is how to measure the functional reserve of the kidney. Is by using renal stress test through an oral protein loading, usually oral proteins, 1 gram per kg body weight. This is oral loading. In Mansoura Urology and Nephrology Center, we have nice work done by to assess renal reserve by infusion of amino acids and dopamine. But the majority of renal stress test is by using oral protein load, 1 gram per kg of body weight. And renal function reserve was defined as the difference between the maximum value of creatinine clearance after protein load, stress GFR, and the baseline creatinine clearance, basal GFR. I want to just to stress renal stress testing is safe, feasible, easy, and inexpensive tool that is able to quantify renal function reserve. So by aging, there is declining of the healthy glomeruli, increasing sclerosis, increasing number of cysts, and decreasing GFR and decreasing function reserve. What about cellular and physiological pathways? This slide shows that all these parameters decreased: vascular density and regulation, antioxidant capacity, telomere length, which is correlated with aging process. The shorter the telomere, the shorter the lifespan of the person, by the way. Autophagy declining. The clotho expression, clotho is responsible about anti-aging, so clotho expression declines with increasing age and oxygen delivery. So all these parameters decrease with aging, and all these cellular and physiological pathways increased by aging. Angiotensin II sensitivity, inflammation, we have what is known as inflammaging, pericyte activation and fibrosis, FGF23 expression, and other senescence pathways and oxidative generation, all these increased by aging. Let us go to a very interesting study. Here, this is the normal BAS stained old glomerulus with a peroxidase stained podocyte nuclei, and here you can find in the Bowman capsule, Bowman space is proteinaceous material. Here, by the way, this is a normal podocyte nuclei, and here is the detached nuclei. And with aging, there is increasing proliferation of podocytes, as you can see by here. This is the mirror image, doubling of the nuclei. When the podocytes proliferate, it leaves its site as a protective function for the glomerulus, and it is lost here in the undetached in Bowman space. This is known as podocyte mitotic catastrophe. We can say that glomerular life cycle follow the star like, so it increases until hypertrophic stress induced protein leak, and then massive podocyte detachment, tuft collapse, and global sclerosis. So this study links the changes that occur with aging to the podocyte hypertrophy and then proliferation and attachment with consequent focal and glomerulosclerosis. So glomerulosclerosis can occur through this pathway by aging, usually global sclerosis. Regarding the this figure shows in a very concentrated manner the age-related signals. You can look here. There's increasing cell senescence. Increasing all these are pro-fibrotic signals. Increasing vascular responses. Inflammations increases. Oxidative damage increases. So all these are age-related signals with subsequent structural and functional changes. Structural changes, glomerulosclerosis, the basement membrane thickening and decreasing in nephron size. And here the reduction of the GFR and reduction of tubular function, tubular dysfunction. So there is decreasing sodium reabsorption, decreasing concentration capacity, and increasing transtubular potassium gradients, and decreased response to fludrocortisone. So a lot of functional abnormalities that put the elderly person in a state of more prone to dehydration and cannot regulate volume status. Again, this is just to summarize. We have clinical macroscopic changes. This is the mass, weight, and length. There is microscopic changes, glomerulosclerosis, interstitial fibrosis, pericapsular fibrosis, glomerular basement membrane thickening, arteriosclerosis, tubular atrophy. Clinical changes, progression of new chronic kidney disease, function and survival after transplantation, functional renal reserve, susceptibility to acute kidney injury, functional changes in the form of GFR in most patients, sodium reabsorption decreases, transtubular potassium gradients, decreasing urine concentration capacity, concentrating capacity. So renal aging is there with structural and function abnormality. What about chronic kidney disease in elderly? This was the World Kidney Day on 13th of March 2014, was concentrating on the kidney ages. So kidneys age just like you. This was the clear message from this World Kidney Day, and they concentrated on the health style in aged persons. One of important point in the aging, all of us know that chronic kidney disease is defined either by the presence of parameters of chronic kidney damage or reduction of GFR less than 60 ml per minute. This is a standard definition. So if we say that we have a person aged 85, does this definition is best fitting? If we find the estimated GFR less than 60, we will say this is a person with chronic kidney disease. These authors discuss this issue under this opinion paper, and they suggested that it's better to use age-adjusted estimated GFR. So for persons in the age of 40, 60 is underestimating the problem of chronic kidney disease, and it's better to use estimated GFR cutoff point 75. And for patients above 75, it's better to use estimated GFR less than 45 instead of 60 ml per minute to avoid overestimation of chronic kidney disease. I am happy because this year we have a specific European clinical renal best practice group guidelines for elderly. So this is a clinical practice guideline on management of older patients with chronic kidney disease, stage 3B. And you can find a lot of definition, how to define if you look at this sector of guideline, here they recommend using estimated equations that correct for differences in creatinine generation rather than plain serum creatinine to assess kidney function in older patients. And they recommend that there is insufficient evidence to prefer one estimating equation over another, since all perform equally, and the substantial misclassification can occur with any of these equations when used in older patients with differing body composition. They recommend the formal measurement of kidney function if more accurate and precise estimation of GFR is required. And they suggested using, this is an important point, is they suggested, the guidelines suggested, using chronic kidney disease epidemiology equation considering combined creatinine and cystatin C, and it can be considered as an acceptable alternative for the formulas. Again, this is suggestion based on weak evidence of research. And they recommend taking account of kidney function when prescribing drug. This is a very important point that I advise all of us to look at kidney function when we prescribe drug, especially chronic drug prescription in elderly. They suggest that the 4 drugs with narrow toxic and therapeutic range, regular measurement of serum concentration can provide useful information for these drug prescription. An interesting question in this sector of the guidelines: what is the most reliable risk model score to predict the progression of chronic kidney disease in older patients with advanced CKD, estimated GFR less than 45 ml per minute per 1.73 square meters? This is very nice. They recommended that the 4-variable kidney failure risk equation, depending on the demographic data, perform sufficiently well for use in older patients with advanced CKD in this guidelines. This is the meta-analysis, a very interesting meta-analysis discussing multinational assessment of accuracy of equations for predicting risk of kidney failure. So 31 cohorts, including this number of participants with chronic kidney disease, 3 to 5, in more than 30 countries, spanning 4 continents. And this is the calculator you can find in Google. Just if you write the name, you will find this variables, and just fill in the space, select male or female, and write the age in years, estimated GFR, and then urine albumin, creatinine, and you will find the answer, and then determine the race, and you will find the answer within the calculator, the expected prediction of renal failure and the progression. This is very interesting data, so it is very simple. This study discussed the issue of multimorbidity among the and correlating chronic kidney disease and patient outcome. So multimorbidity as a specific combinations of chronic condition showed an effect on mortality which would be higher than the risk attributable to individual comorbidities or morbidities. So the presence of comorbidities increase the risk of mortality. The most important predicting pattern for mortality was the combination of atrial fibrillation, chronic kidney disease, and visual impairment after 3 years. So it is better to target the multi-comorbidities in this aged population. You can look at the different morbidities: atrial fibrillation, COPD, malignancies, anemia, and chronic kidney disease. Here, yes and no. No and yes. The no is associated with better survival, and yes is associated with worsened survival. And this is the CKD and the outcome, the rest of the classification. And it just to show the unadjusted Cox proportional hazard model of time to death for the most associated individual morbidities and the multi-morbidity combination at 3 years of follow-up. You can look here. 1 disease, it is the hazards. 2 diseases, the hazard increased. 3 diseases, more and more increase in the hazards of mortality. An interesting point: occurrence of hypoglycemia in patients with chronic kidney disease or low GFR in elderly. Here you can observe, this is the for persons using anti-hyperglycemic medication. Here, the lower the estimated GFR, the higher the percentage and the number of patients develop hypoglycemia. This is for anti-hyperglycemic users, so you can find here, and this is for non-users. This means that hypoglycemia can occur, and the presence of chronic kidney disease, especially stage 4 and 5, is a risky situation for hypoglycemia. Another important point is the diet, and it's important to know what should we eat. even in elderly. The excess protein intake is bad. So excess protein intake relative to fiber, and fiber is good. We should encourage fiber eating because eating fiber leads to antioxidative, and it has fiber eaters enjoy a better lifestyle and a better cardiovascular state. So excess protein to fiber is evident to be bad and associated with problems of cardiovascular. Uric acid is bad too. The hyperuricemia is associated with deterioration of kidney function in elderly patients with hypertension. This to stress on the management of hyperuricemia in elderly patients with hypertension. Regarding gout, occurrence of gout in elderly persons, this is the cohort of patients including 280,000 persons aged above the age of 66 years. What you see, the lower the GFR and the higher of the stage of chronic kidney disease, the higher the percentage cumulative incidence of gout in men and women. Here the dialysis reduced uric acid, but here this is the percentage. If you compare stages, different stages, so you'll find stage 4 and 5 have higher incidence of gout in both men and women. And you can look at the number, because numbers don't lie. So here, if we are looking at women, this is a different GFR. Here, this is the incidence rate of gout. Here, 2%, 2.6, 4.6, 8. This means the lower the estimated GFR, the higher the incidence. And the same for men, the higher is either adjusted or not adjusted. The same information. This is 3-year cumulative incidence of